Picture yourself on your second day at the pediatric emergency room. The previous day marked your introduction to the role. And today you are already interacting with patients, providing guidance to the nursing staff, engaging in discussions with senior colleagues, and demonstrating your capability, despite it only being your second day. However, you're preoccupied by the desire for that one clinical case that will allow you to showcase your clinical acumen and practical approach to patient care. This case could determine your future. When you will return to work the next day, you sense that whispers and recognition are accompanying your presence. The department head will likely request your insights on diagnosis and treatment. Then, I hear Dr. Smith urgently summoning me to the emergency room. Urgency in medicine sparks thoughts of critical situations, such as respiratory distress, shock, or seizures. I think that even after 5 years of my experience, an urgent call to the emergency room still evokes me questions and emotions. This urgency stems from the profound responsibility for another person's life. It reassures me that I have embarked on a marathon where the importance of confidence in success becomes evident. Although a supportive team surrounds you, it's ultimately your responsibility. Dr. Smith's voice, echoing deeper into my soul, signals the start of a new phase. En route to the emergency room, the nurse provides information about the patient. A previously healthy 5-year-old girl who abruptly fell ill during a friend's birthday party. She experienced vomiting, lost consciousness, and exhibited bluish discoloration. An ambulance was dispatched, and the paramedic initiated intubation, ventilation, intravenous sodium chloride, and observed her pulse at 51 beats per minute. On arrival at the scene, I am immediately involved in the examination. The endotracheal tube, sized 5, is positioned at a depth of 15 centimeters, resulting in coarse breath sounds during inhalation. With good and symmetric breathing on both sides. Oxygen saturation remains at 99% on 30% oxygen, indicating respiratory stability. Attention now shifts to hemodynamics. Blood pressure, at 90/60ths of a millimeter of mercury, has remained constant at 50 to 51. Skin color is normal. Peripheral pulses are palpable, and capillary refill registers at 2 seconds. Thoughts race to maintain focus, determining the most critical issue at hand. Is the patient stable? Yes. Does the bradycardia require treatment? No. I asked the nurse to perform an electrocardiogram, explaining that the patient is stable. And at this stage, it's crucial to quickly understand the cause of her bradycardia, which will guide our subsequent decisions. The electrocardiogram shows sinus rhythm. I remember my cardiology professor mentioning that sinus bradycardia is rarely related to heart problems. I confidently said this out loud, which seemed to improve the atmosphere of our communication. What's next? Always consider the worst. Recalling the PALS algorithm. Things we often think of, but generally are obvious. The H's and T's. It's time to get some tests done. I asked the nurse to take a glucose test. And for the first time, I saw a smile on her face. She seems to like the way my mind works. And I must admit, I'm quite fond of it too.
The glucose level is normal.
While waiting for the other test results, I request a chest X-ray to primarily check the placement of the endotracheal tube, look for pneumothorax, and assess heart size. The X-ray didn't surprise me. Everything appeared normal, which was expected. Finally, I received the test results, which also appear fine. Even the lactate level was within the normal range, which meant that help was provided appropriately and in a timely manner before arriving at the hospital. Things also known as things that I need to remember. Now, the possibilities are head trauma or hypothyroidism malnutrition. I decide to go back to the neurological examination. The pupils respond well. There's no reaction to pain, no spontaneous breathing, and no cough reflex. What to do, Dr. Smith? A brain computerized tomography? Hemodynamically stable. Brain CT. I call the neurosurgeon. I look at the clock. 30 minutes have passed since the child arrived. It feels like I've run a marathon. And now I'm beginning to understand where the word marathon came from.